My name is George Smith, and I'm an intern at UT Health Medical Research Center, and I'm going to be covering the studies and treatment of scapular dyskinesis. Scapular dyskinesis is a disease in which there is a deviation in the normal position of the scapula during the restive and active motion of the shoulder. The scapula, which is also known as the shoulder bone, is the bone that connects the humerus with the clavicle. It plays an important role in stabilization of other bones when going through motions of the shoulder. Protraction and retraction assist with movement of the pectoral girdle. Elevation and depression assist with the movement of the shoulder capsule. And lastly, upward and downward rotation assists with the stabilization of the shoulder during excessive motion of the arm. There are three types of scapular dyskinesis. Type 1 being inferomedial scapular border prominence, which is when there is tightness in the anterior side of the shoulder, coupled with weakness of the lower trapezius and serratus anterior muscles. Type 2 is medial border prominence, which is when there is winging of the entire medial border when at rest. And lastly, type 3 is superomedial border prominence, which is when there is prominence of the superior medial border of the scapula and is often coupled with other injuries such as shoulder impingement or rotator cuff injuries. Causes can be muscle weakness or muscle imbalances, but overhead mechanics and overuse and repetitive motions are also potential causes. Symptoms may include pain and tenderness around the scapula when performing movements, popping sensation around the scapula with movement, loss of strength, and or asymmetrical posture. When diagnosing for scapular dyskinesis, a test performed is the Scapular Dyskinesis Test, or SDT, which includes finding any abnormal movement of the scapula, such as watching the scapula during shoulder flexion, and it has been shown to be one of the most common ways to assess for abnormal movement. After a successful diagnosis, the following tests can be performed to find symptoms. The scapular retraction test, which is checking if pain is reduced with active elevation and applying a posterior tilt and external rotation motion to the scapula. The scapular assistance test, which is checking if range of motion is increased or pain is reduced when assisting with the scapular upward rotation during active upward elevation. Isometric scapular pinch test, which is when the patient is in a standing position and is asked to actively squeeze or retract the scapula together as hard as possible. Lastly is a scapular load test, which is for checking for scapular movement above 1.5 inches when the manual load is being applied in anterior, posterior, inferior, or superior direction to the arm. After diagnosis, the patient should seek one of the many conservative treatments afterwards. In January 2019, an article was published titled "Swimming as Treatment of Scapular Dyskinesis." A case was presented with a 19-year-old male with scapular dyskinesis due to axonal involvement of the long thoracic nerve and parathesis of the anterior serratus muscle. The patient had previously completed a 10-week session with a physical therapist focusing on analgesia and passive mobilization, but with no pain reduction. The patient had undergone a 3-month swimming program consisting of 3 60-minute sessions a week. And to straighten the periscapular muscles, 4 classic styles of swimming were practiced along with the front crawl, breaststroke, and backstroke being alternated during training. After the swimming program, this patient had experienced reduction in pain and functional recovery of the upper limb, with reduction of the wing scapula, and concluding that aquatic therapy was a viable method for treatment of scapular dyskinesis. In July 2019, an article titled "Effects of Trapezius Kinesiotaping on Scapular Kinematics and Associated Muscular Activation in Subjects with Scapular Dyskinesis" was published, with the objective to investigate the immediate effect of kinesiotaping over the trapezius in scapular kinematics and muscular activation in the different dyskinesis patterns. The trial included 54 patients with inferior angle prominence, medial border prominence, and mixed patterns, being recruited with kinesiotaping being applied over the upper, middle, and lower trapezius. Results were measured by data collection from the scapular kinematics and electromyographic of the trapezius and serratus anterior during scapular plane elevation without taping and after taping. Results showed that upper trap taping decreased upper trap activity with increased posterior tipping. Middle trap taping increased upper trap activity, and with no kinematic difference found in lower trap taping. In conclusion, reduced upper trap activity and scapular posterior tipping with upper trap taping was shown and can assist with normalizing scapular movements. Lastly, in May 2018, an article titled Scapular Dyskinesis and Sick Syndrome in Patients with a Chronic Type 3 Acromioclavicular Dislocation Results of Rehabilitation. Due to the prominence of scapular dyskinesis being associated with acromioclavicular dislocations, a rehabilitation program was adopted to improve shoulder function and improving scapular dyskinesis in patients with chronic acromioclavicular dislocation. 24 patients diagnosed with chronic type 3 acromioclavicular dislocation and scapular dyskinesis were put in a rehabilitation protocol and assessed. The protocol consisted of 12 strengthening and stretching exercises of the scapulae, with follow-ups being after 6 weeks, 6 months, and 12 months. Results were measured using the 6 scapula rating scale, with shoulder function being measured with a constant score and subjective shoulder value. After 12 months, scapular dyskinesis was no longer present in 18 out of 23 patients. The 6 scapula syndrome in 4 patients with 6 scapula was 7.5 points, and the average constant score and subjective shoulder value rose by 85 points. The study concluded that scapular dyskinesis can be treated with proper strengthening and stretching exercise of the scapula within 6 weeks, but patients who did not respond to the treatment will not do so with an extended rehabilitation time. In conclusion, scapular dyskinesis is sometimes overlooked as an underlying cause for another injury, but if left untreated can rise to be a primary cause for injury. It can be a primary cause for injury, although there are various ways to approach treatment. Articles have shown that physical therapy, aquatic therapy, and kinesiotaping are viable methods of treatment for scapular dyskinesis and should be sought if symptoms occur.